A very good evening. It's my pleasure to welcome you all for this special webinar, which has been organized by the Society of Fetal Medicine on the occasion of the World Mitochondrial Disease Day. Now, though mitochondrial disease is rare, but it does have profound implications. Hence, as a medical community, it is important that we are aware about it. It has it's a part of a genetic uh, disease which has a very typical inheritance, and hence it is really, really important that we be aware about it. And I think who else than the Society of Fetal Medicine would bring out a complete webinar on this. And we have a team of experts today. We will have our own Dr. Ratnapuri, who will take us through the mitochondrial inheritance and how the inheritance pattern is. And then Dr. Shagun Agrawal is going to moderate a panel, and we have a bunch of expert panelists who will tell us about the complexities of the mitochondrial disease and what is new, what is the diagnostic criteria, and everything. So I welcome you all again, and I first invite Dr. Ratnapuri ma'am. She doesn't require any introductions. I'm not going to waste time. I would rather give her those extra minutes to enlighten us more. And Dr. Ratnapuri is going to take us through her lecture on mitochondrial inheritance. Madam, over to you.
Thank you so much, sir. And like you said, to start without much ado, are my slides seen?
Yes,
are my
ma'am.
slides seen?
Yes, ma'am.
Okay. So, so this is a fairly new topic that we are discussing in SFM. And just to start with some basics before Dr. Shagun and a very expert panel takes forward case scenarios. And so we know that mitochondria is a cellular organelle, and it is very, very important because it's the powerhouse of energy. And its main role is in the formation of ATP. Now, we know that this mitochondria is in the cytoplasm, as you can see here, and this is the nucleus. And the mitochondria is controlled and is, it works, the proteins are formed through the action of two DNA sources. One is the mitochondrial DNA. These are the circular DNAs that you see here inside the mitochondria. And the other is the nuclear DNA. So there are over 1,000 proteins that are required to maintain the mitochondria. And these proteins originate from both forms of DNA. And I think the most important thing to know, we'll come into the structure of the mitochondria. You can see that this DNA is circular. But the most important thing to know is that in every cell, there are multiple mitochondria, and each mitochondria has 2 to 10 multiple copies of the mitochondrial DNA. So because this is a concept which will come up again and again, and therefore this basic is important. So we said it's a circular DNA. You can see that this is how it is. It's a double-stranded circular DNA, unlike the other nuclear DNA. And there are 37 genes which are protein coding. And these code for 13 proteins, 22 transfer RNAs, and 2 ribosomal RNAs. So this has a role in protein translation. Now, just to differentiate between the nuclear and the mitochondrial DNA, this is linear, the mitochondrial is circular. The mitochondrial DNA is composed of about 16,569 DNA base pairs, whereas the nuclear DNA we know is about 3 billion base pairs. There are 20,000 genes here, but they are, like I've already said, 30,000 genes which code for these proteins. There is non-coding region within the nuclear DNA, but there is no non-coding region like the introns, etc., in the mitochondrial DNA. And what is also very important is that there is a lack of mitochondrial DNA repair mechanisms, and therefore there is an increased rate of these DNA mutations. And so this becomes very, very relevant because we acquire many mitochondrial DNA mutations. And you can see that the nuclear DNA is inherited from all ancestors. It can come down males and females. They follow the typical Mendelian and the Mendelian patterns of inheritance, whereas the mitochondrial DNA is inherited only from a single lineage, and that is the maternal lineage. I love this diagram, which is why I bring it here. And but all the functions are going to be discussed in the next panel. But really, this just shows how powerful the mitochondria is and how important it is for the functioning of our body. And anything that impacts the mitochondria function will impact the production of energy, growth, development. There'll be neuroregression, etc. Now, coming back to the mitochondrial inheritance and what is unique about the mitochondrial DNA is that there are three features that are very, very unusual for the mitochondria, and that's maternal inheritance, replicative segregation, homo and heteroplasmy, and a threshold effect. They sound like mouthfuls, and hopefully I'll be able to explain these to you. This is fairly simple. The mitochondria which are there in the gamete are purely maternal. The sperm mitochondria are not passed into the zygote. And so it's mainly the maternal mitochondrial DNA. And you can see in this pedigree that if there is an affected male, the offspring and the other members here are not affected. Whereas if we have an affected female, these mutant mitochondria will go to the other members. They are transmitted because that's where the mitochondria come from. The next concept is replicative segregation. Now, to put it very simply, we can see that here, this is the cell where you have a large number of mitochondria, and they are a very, very discrete functional unit. They replicate on their own by binary fission. So whenever there is cell division, the mitochondria segregate randomly. It has nothing to do with the fact that you have a daughter cell which is dividing, you have a parent cell which is dividing into two daughter cells. So you can see here that these mitochondria are just on their own, like we say, they're on their own trip, and they just divide and segregate in a random fashion. So if we see here that if one of the progenitor cells has a mutation in the mitochondrial DNA, this mutation in the daughter cells can be present in differing amounts. Okay, so this is what is very important, this explanation, because of the random distribution of the mitochondria in the daughter cells. So the mutant load also varies. Now, in every cell, there are multiple mitochondria, and in every mitochondria, there are multiple circular mitochondrial DNA. Now, sometimes I also told you that these mitochondria, if the DNA repair mechanisms are not functioning, and therefore they accumulate these DNA mutations. So in the mitochondria, there can be two populations of cells. For example, if we consider the pink is the normal and the green is the mutated, here we have a few mutated cells. Now, during cell division, we said that there is a random distribution. In some, they could be more green and therefore normal, whereas in the other daughter cell, they could be more pink and therefore more abnormal. So this is heteroplasmy, the presence of two cell populations. Now, it is nature's way that this heteroplasmy drifts towards a uniform population, and that is homoplasmy. So it can be pure normal or it can be pure mutant. And when it crosses a certain threshold for a mutant, that threshold, then there is manifestation of the phenotype. Now, this threshold can differ from tissue to tissue. And therefore, we see that there is so much of variable clinical features in patients with mitochondrial disorders. So this is just explaining the same thing. So here you have the mitochondria. This is pure normal. This is heteroplasmy, two populations of cells. This is homoplasmy and normal. And this is homoplasmy and mutated. And somewhere in between, you don't have to have pure homoplasmy to have a phenotype. If the number of mutated mitochondrial DNA crosses a threshold, cellular dysfunction will happen. And like we said, this is variable for different tissues, but we know that the tissues that require and demand more energy are the ones that are impacted in mitochondrial disorders, like the CNS, the cardiac muscle, the type 1 skeletal fibers, the liver, and the kidney. So kind of like to summarize, what are the characteristics of mitochondrial inheritance? All children of a female homoplasmic for a mutation. That means if you have a female and all her mitochondrial DNA have the mutation, this will be inherited by the children, by her offspring, because the mitochondria from the mother go into the children. Whilst the children of males who are affected will not be affected because the male mitochondria does not go into the gamete. Females who are heteroplasmic for any mitochondrial mutation, for example, a point mutation or a duplication, will pass these on to all of their children. But the fraction of the mutation that will go is very variable, and therefore the risk and the severity of the disease is also going to be variable because that is dependent on the amount of mutant mitochondria that the offspring has inherited from the mother. Okay? Now, there is another concept which is referred to as a bottleneck, and I'll talk about that later. It's like the neck of a bottle. It squeezes some mitochondria into it, which can be either normal or mutant, and then it opens up where that mitochondrial DNA then divides again for the cell. And heteroplasmic deletions are generally not inheritable. Now, the fraction of the mutant mitochondria in different tissues of an individual who's got a mutation but is heteroplasmic for that mutation can also vary. And therefore, you get a lot of what we call pleiotypal and variable expression of the phenotype in different tissues of the same people, as well as in different individuals with the same mutation who can have different expression of the disease. So this whole concept of homoplasmy, heteroplasmy, the bottleneck impact, the mitochondria just going from the mother to the offspring are important to grasp. So this we've understood that the mitochondria are under dual control. The nuclear DNA that follows the Mendelian pattern of inheritance and the mitochondrial DNA that follows the mitochondrial or the maternal pattern of inheritance. And so we see here that there is only a maternal line transmission. So this is coming again and again for everyone to get the concept. From the male, there is no transmission of the disease. From the female, there is transmission of the disease because the mutant mitochondria will go. And so both males and females are affected. And the proportion also varies because it's under a lot of environmental and other genetic modifier controls. So for some disorders like Lyme, there are more males affected than females. And so it varies for the different mitochondrial disorders. So this is a typical mitochondrial pattern of inheritance pedigree. So you can have an affected, so that means this female, she does not have symptoms, but she has mutation, so she would be heteroplasmy. All daughters of an affected or a carrier female are at themselves at risk of transmitting the disease to their offspring. They can be affected and they can transmit the disease to the offspring. All the sons are at risk of having the disease, either being symptomatic or not being symptomatic, but they're not at risk for transmitting the disease. And like I've always told you, the sex varies as per the disorder. So what are the challenges in genetic counseling? So if you have female carriers of heteroplasmic point mutations or duplications, they will transmit some of the DNA to their offspring. Now, in the oocyte, the mitochondrial number is reduced before it is again amplified to the huge total that is seen in the matured oocytes. And so this is what I referred to previously as the bottleneck effect, just like the neck of a bottle where you're trying to squeeze in something. So just one or two will go in, and then they multiply and amplify to carry on the functions of the organism and the tissue and the cell. So the fraction of the mutant DNA that is inherited by each child is very variable. It depends what just slips through the bottleneck. And this again creates a lot of challenge in prenatal testing because we don't know how much of the mutant DNA has gone. It can be tissue specific, etc. And these things are going to be covered in the panel discussion. So when we talk about recurrence risk, if it's a mitochondrial DNA disorder, it could be de novo, no family history. A lot of deletions are de novo or sporadic, or it could come down the maternal lineage. So we've talked about if the mother is heteroplasmic or homoplasmic for any of these variants, she will transmit it. There'll be variable penetrance and clinical variation, even for her offspring. And even if there is homoplasmy, if all the mitochondrial mutation, if all the mitochondria are mutated, even then there is a variation because we don't know how it is in different tissues of that individual. Most of the deletions, like I told you, are sporadic, and therefore there is a very low risk of recurrence for siblings, whereas there is some risk of transmission to the offspring. And therefore, with these challenges of bottleneck, the differences in the various types of mutations, the differences in the tissues, makes genetic counseling very, very challenging. And you have to know which is the appropriate tissue to test in pregnant. First of all, making the diagnosis in the individual. It's not necessary that all the mutations would be present in the blood. They can also decrease with increasing age. This is also a phenomenon that has been reported. We may need to test different tissues, for example, the skeletal muscle, the urine, sometimes the buccal swab. And once you confirm the diagnosis in the individual, we also confirm that what is the extent of involvement, what is the heteroplasmy, and is it homoplasmic? And then if we have to counsel for prenatal diagnosis, again, there is the whole challenge of which tissue in pregnancy. Is it going to vary as per the development? And is it representative of a postnatal sample? So therefore, I think just to summarize everything I've said, the challenges to arrive at a diagnosis. So we have to be very, very clinically alert and think that this is a disorder because of a mitochondrial DNA mutation, because there's a lot of heterogeneity and variability. The concept of heteroplasmy, tissue variability, and also variation with time, because remember I told you mitochondrial mutations can accumulate because the repair mechanisms of the body are poor. You would not get a specific genotype-phenotype correlation that runs true in the family. The bottleneck hypothesis again makes prenatal testing slightly challenging because you don't know what the mutation load is going to be in the offspring as well as in the different tissues of the offspring. And is this going to shift in utero after birth as the mitotic segregation and cell division continues? So thank you very much. I'll be happy to take any questions, or maybe that will be at the end. So I now invite, I think we'll carry on with the panel discussion. I now invite Dr. Shagun Agarwal. She's going to lead the panel. I think Dr. Shagun also does not need any introduction to this audience. She's the professor and head of the genetic department at the Nizam's Institute in Hyderabad. Over to you, Shagun.
Thank you so much, ma'am, and thanks for making my work easy by telling us about the mitochondrial inheritance. So I'm now going to go through some cases, and I have an expert group of panelists with me, and many of them also wear multiple hats, and especially the fetal medicine and the obstetricians, many of them are experts in both the domains. So I would just like to introduce all my panelists here. So we have,
Sorry,
yes.
sorry, ma'am. Can you do the trade partner video for your panel?
Oh, sure, sure.
Yeah.
Yes, yes, of course. Let's do that. Please.
Atul? You can start.
Yes. The full screen is visible, right?
Yes, Dr. Shagun. Thank you.
So I would like to first introduce my expert panelists. So we have three very senior medical geneticists with us. Dr. Ashwin Dalal, who is the head of the diagnostics division at Center for DNA Fingerprinting and Diagnostics. Dr. Sunita Bijarne Mahai, who is the senior consultant geneticist at Sir Gangaram Hospital, New Delhi, and Dr. Udaya Kotecha, who is a senior medical geneticist with Newburgh Supratex. Then, of course, we have the fetal medicine specialists. Three very senior specialists are there with us today. Dr. Sita Ramamurthy Paul, that I hope she also doesn't need an introduction to this audience. She is the president of the West Bengal chapter of SFM and holds many more positions in various professional societies. Dr. Nitin Gupta, who is the president of the SFM's Rajasthan chapter, and Dr. Gayatri Indla, who's the director of Lotus Fetal Medicine Center, Kurnool, AP. And we have two very senior obstetricians with us, Dr. Manjula Rao, who's the head of the department of Obs and Gynae at Durgabhai Deshmukh Hospital in Hyderabad, and Dr. Sumitra, who is a senior professor Obs and Gynae at Safdarjung Hospital, New Delhi. And as I was mentioning earlier, many of our fetal medicine and obstetrician colleagues are wearing multiple hats, and then they are experts in obstetrics as well as fetal imaging. So I welcome all of you panelists. So we would be going through three case scenarios today. And as Ratna ma'am has told, about the mitochondrial disorders and the inheritance pattern, which is very specific for the mitochondrial mutations. And also, as Madam mentioned, there are certain nuclear DNA mutations also, which would manifest with a similar kind of a phenotype. So let us now see how these present in the clinic, and especially the reproductive scenarios, and how we need to be aware of these and tackle this. I think the slides are not moving. 1 second, I'll just reshare them. Okay. So now moving on to the first case. So here what we see is that this is a consanguineously married couple, and they had actually come to our OPD during early pregnancies, around 6 weeks gestation. And they gave history that they had a 4-year-old baby who had expired. And the history of that child was that initially the child during the perinatal period, there were no significant events, and the child was actually doing quite well till around 11 months of age. But then after that, she had a kind of a developmental arrest, and she never attained independent standing or walking. And subsequently, by 18 months, she started losing her motor and language milestones, also developed failure to thrive and certain involuntary movements. And finally, she had a severe episode of seizures, and which was followed by her death at around 4 years of age. So that's a history with which they had walked into our genetics OPD. So now I would first like to call upon Dr. Sumitra. So as an obstetrician, Dr. Sumitra, you're there, ma'am?
Yes, I'm there.
Yes. Yeah. So as an obstetrician now, if this patient has come to you and she gives this history, so what would you be thinking, and would you be wanting to refer them to some specialist? Who would you consider referring? And she has come to you in early pregnancy. So would you want to wait and refer her directly for an amniocentesis at 16 weeks? Or what do you feel? What would be the right time to send her to a specialist?
Yeah, so good evening and thank you to the organizers for this very kind invitation to involve me. So coming to your questions, Dr. Shakun, one thing is that looking at the pedigree, it looks there is a consanguinity, and there is a child which was affected, in a very young age, and likely because the perinatal period was absolutely normal. So I would say that there is definitely a risk that this child would be having some genetic disorder that comes to our mind. Maybe we can, if we see the three-generation pedigree or an extended pedigree, we would be able to comment better on recessive disorder or some such thing. And also, as you said that, yes, I would like to, because thinking of a genetic disorder, I would like to refer this couple to a geneticist. So because the child, the proband is not there, but the examination of the couple as well as the extended carrier screening, if it needs to be done, or the counseling, it could be very extensive. So for that, the couple has to be sent to a specialist, and I would like to send them right away because. If at all they require a prenatal, the 11 weeks to 13 weeks time becomes ideal because that is the time when the NT scan can be done, the serum screening can be done along with it. Once they've been counseled and if carrier screening is required and has been done, then the prenatal test as such can be advised. So definitely they would require a counseling, they would require reference immediately at this time only.
So you would not like to wait also till NT scan? So you want to refer them right away?
Yes, because I think the if the couple is investigated and if the probands some sort of DNA or something is available, then the investigation can be done right away. And by the time it is 11 to 13, we have arrived at probably arrived at a certain syndrome or a disorder which we would like to investigate further to the to the
Right.
current pregnancy also. So why lose that time?
Yes, definitely. Yeah, thank you. So, as you mentioned correctly, so genetic testing usually takes time. So, most of the tests, the turnaround time is around 4 weeks. It takes a month to. So, we are aiming to provide them prenatal by the first trimester after the NT scan. So, by that time, this is the right window where if we refer them, we could do this workup and complete it. So thank you, Dr. Sumitra. So then now the couple has gone to the geneticist. So Dr. Rudya, so with this history, they've come to you. So what would you like to further elicit here? So would you want to review something? Would you want to see some other investigations and all?
Good evening, everyone, and thank you, SFM, for this opportunity. Yes, I think in this history, I would like some more information on the proband. What was the baseline blood work done? Whether there was any neuroimaging done, because there's some history of regression. So there's possibility that we would be looking at leukodystrophy or white matter changes. Also, since there is an pregnancy, I would like to know whether the proband sample, DNA sample, has been stored anywhere, or whether they have preserved a dried cord, or it's sometimes even if a blood tandem mass spectrometry has been done, is it possible to retrieve the dried blood specimen? So this is the minimum information that I would first seek out.
Yeah, and probably it would also be good if we have photographs of the child, because very often nowadays parents are having, everybody is having mobile, so they do carry photographs of the children, and even the medical records and all also sometimes those also can be retrieved. So all the information which I mean, as a geneticist, we would need to see. So we can gather all that information by collecting all these things from the parents. So here for this child now, they did have the photographs of the child. This was at around 1.5, 2 years. So, and then of course, luckily these parents had preserved the records of the child. Unfortunately, many parents do throw away the records. So that is a sad thing, because because of the emotional trauma that they are going through, many parents do end up throwing away the records. So it's very important to kind of, encourage our patients at least to not discard of the records. So we should try to gather as much information as possible, as Dr. Udaya has said. So here, Dr. Udaya, so now we have this much information. The child did have certain neuroimaging abnormalities, mild elevation of ammonia, and some axonal neuropathy was there, and an abnormal EEG was there. rest of the basic blood workup was unremarkable. So now what would you like to do next? Let's see, assume that the child sample is available or not available. So in both of the scenarios, how would you like to proceed?
I think the initial workup, neither the photographs are giving out any, definitive pathognomic signs or symptoms to point towards a single disorder. So if the child sample is available, then I would like to start by testing the child sample. And because you said they are consanguineous and there was an there is a higher chance of an autosomal recessive inheritance. So with the child sample, we could go ahead with exome sequencing. You could also do an additional mitochondrial genome sequencing of the stored DNA. But I think the first important thing is also to know that how much sample is available, what is the quality and quantity. If it is minimal, even if the sample is available, but if it is minimal, since it's a precious one, you could also discuss the fact that start out with the parents and then follow up with testing the child for that particular mutation in an attempt to prove the diagnosis with the remaining precious sample that is available. If the child sample is not available, we do not have any option. So we could discuss expanded carrier screening. But at the end of the day, I think it is important to tell them that the carrier screening might pull out variants, but there is no way that we are going to ever confirm in the absence of the availability of the child's DNA that these were the mutations that he or she had inherited. But if the carrier screening does give us pathogenic or likely pathogenic variants, which could explain the phenotype, then probably we have hit at the answer at what is the familial disorder with a good certainty. But there is nothing to replace the sample of the testing of an affected person.
And is there any role of doing a chromosomal microarray here for the child or for the parents?
Here, since the parents were consanguineous and overall there is not much dysmorphism, probably I would not place it as on a higher end of my test of lists. Yes, we could always discuss it if the exome comes out to be negative. The second thing is most of the exomes now have an inherent CNV calling. Though, of course, if you get a CNV, that is a bonus. If you do not get anything, it never means that you have excluded CNV. So if there's a precious sample around, probably I would like to start with an exome itself. And we could add in mitochondrial.
Yeah.
And for
any
the
role
parents
of
also,
parental microarray, anything? Any role of parental microarray in such situations?
parental microarray, no, but probably parental karyotype if you're looking for a balanced translocation. But again, overall, given the pedigree and the symptomatology, that doesn't seem to be very high on my list of suspicion.
So it's very important, like as Dr. Udaya mentioned, that we, look at the pedigree. We are seeing consanguinity, and we see the phenotype of the proband, because when we have regression, when we have MRI abnormalities, we are more thinking of in terms of a neurometabolic disorder, which are not really chromosomal in etiology. So here the test of choice, we would basically be thinking of a autosomal recessive condition, and that's why we are proceeding in this manner for the testing. And Dr. Rudya, in case the child sample is sufficient and all, and we are able to do the testing now that she's pregnant, is there still a role of offering an expanded carrier screening to this couple?
Hello.
Yeah, Dr. Rudya, please. They are a consanguineous couple. Could we also consider them offering an expanded carrier screening here? Or at least for certain other conditions, could it be offered? I think you're not audible.
Hello.
Hello, Dr. Udaya?
Hello, am I audible now?
Yes, please.
So what I was saying is we should still consider carrier screening even though there's an ongoing pregnancy, because if it does provide us results, we will be able to offer prenatal testing, though it is possible that we might not be able to reach in time for CVS and we might have to stretch till amnio. That would depend upon how fast the test turnaround is.
And what about screening for thalassemia or spinal muscular atrophy? Like, should that
would be that that is something that will go along with the part of the expanded carrier screening, so that the routine carrier screening will always take place along with HPLC as well as SMA, which has been recently introduced by the IAMG and the SFM. That those two, irrespective whatever the family history, that needs to be discussed and the couple need to be counseled. And again, telling them that these disorders are very different from what we are suspecting in the family. It is possible that they turn out to be carriers of more than one disorder, which is more common when there is consanguinity.
Thank you, Dr. Udaya. So one of the important point here again is that at least even if a couple is consanguineous or non-consanguineous, at least for a thalassemia and spinal muscular atrophy, we should be offering carrier screening to everybody. And here, of course, because of consanguinity, we could consider an expanded screening also. So now we move on to the report. So this is the report from the child. So luckily, this couple had stored the child's umbilical cord. So this is a very common practice in southern part of India. And using that cord, we were able to extract the DNA, and then the child was found to have a homozygous variant in this particular gene. And this was a previously known pathogenic variant. So mutations in this gene are known to cause a kind of a mitochondriopathy. This is a complex 4 deficiency. So, and this couple did opt for an expanded carrier screening also using NGS. And here we are seeing now that both the partners, as expected, are heterozygous carrier of the SERF1 variant. But in addition, both of them are also heterozygous for BRCA2 mutation. And actually, this variant is also a pathogenic variant. And in addition, wife is carriers of 2 more pathogenic variants in autosomal recessive diseases. Husband is not, and husband is carrier of another mutation in an autosomal recessive disease, but wife is not. And SMA carrier testing, which was done, here wife was found to not be a carrier. So now with this kind of a huge list of variants which has come, and this is very common nowadays, many couples are opting for these kind of expanded carrier screening. So they come to us with all these reports. So I'll like to ask Dr. Sunita, how would you like to counsel this couple?
Thank you, Shagun, and thank you, organizers, for the invitation. So, as we know that this couple is consanguineous and that they already have lost this child, and now we also have the genetic diagnosis. Basically, this is a recessive disorder, even though it is a mitochondrial disorder, but the inheritance is autosomal recessive because it is due to a nuclear gene. And so that is why the risk in this couple, in this pregnancy and any other subsequent pregnancies is 25%. So that is, I'm talking about SERF1, which is only one of the genes. So for each disorder that the couple is a carrier of, a shared carrier of, the risk is 25%. So here we see, Shagun, that there are 2 disorders actually.
Yes, ma'am.
One disorder, yeah, they have already experienced with this with their previous child. So definitely this 25% risk is definitely there. But you can add on the second risk because of the BRCA2 variant, which is also pathogenic. And both of them, both the husband and wife are carriers. So basically, if you combine the 2 disorders, then the risk becomes almost like 3/8, which is 43%. So, but for the rest of the conditions, we need not bother because they are not, both of them are not carriers. So this is fine. So, Shagun, does this answer your question? Yeah.
Yes, ma'am. In addition, now we are seeing here like this BRCA2 variant is also like besides the in autosomal recessive form causing Fanconi anemia. So
Yes.
this is again one of the common hereditary breast and ovarian cancer gene, and which is autosomal dominantly inherited. So how would we counsel them for that? Actually, they are otherwise and there is no family history of any cancer.
Yeah, so this is another feature of carrier screening because you should be ready for such surprises. So basically, BRCA2 gene is related to our cell, machinery and its cell division and further. So if there is a variant in this gene, in the dominant state, it is a predisposition to cancer, breast cancer. But if the both copies of the gene are defective, then not only is it a risk for cancer, but early in life, you actually manifest with more severe conditions like Fanconi anemia. So that's how this is. So it's basically at the moment in the childhood, the risk would not be so much for cancer, but for the Fanconi. So that's why this is a totally genetic disorder, whereas a cancer is just a predisposition. Like both the husband and wife are carriers for one variant each. So both of them are at risk for cancer in their life. But that's not the situation here. We are only here counseling about this pregnancy.
Yes, ma'am. But sometimes, I mean, now that we counsel them, the couple, should we also be counseling them about the risk of cancer in their child or not? I mean, how much information or what information should we give them? Like, what is the risk of cancer in the child eventually? Can we tell them some more additional information, or should we tell them this information at this point?
We cannot hide this information, but we can definitely focus more on the situation here and tell them about what needs to be done in this scenario. And we should always rather ask them to come back at a later date and get on with the other risks that are there. It's all about counseling. Yes, you have to do it very sensitively so that the couple not only understands, but also does not get, very scared or anything.
Anxious.
Anxious.
So as Dr. Sunita said, so like in the dominant form or in the heterozygous form, so BRCA2 is a cancer susceptibility gene. So one thing, the cancer development happens in the adulthood, and the second thing, it's the risk of developing cancer is somewhere to the tune of 50 to 80%. So it's not like everybody with that mutation would have cancer. So this is something which we would need to counsel the couple very sensitively. And here basically the purpose of doing an expanded carrier screening or prenatal testing is most of the time for childhood onset moderate to severe disorders, but again sometimes it is a couple's choices and we have to finally leave the decision to them. So with the counseling now, then the couple goes to the fetal medicine consultant now, so Dr. Gayatri. So they are still very anxious. They have undergone multiple counseling sessions, but they are seeing this report and there are so many variants showing, and they are worried about their health, the baby's health. So what would you further offer them, or what prenatal testing? So how would you offer them? What testing would you offer them?
A very good evening, everyone. Thank you, Shagun ma'am, and thank you, SFM, for giving me this opportunity. Am I audible?
Yes, Dr. Gayatri, please go on.
From seeing her previous couples reports and previous child reports, so we are dealing with an autosomal recessive condition that's going on in the family. In addition, we have also found the parents to be carriers for another mutation which can be inherited as autosomal recessive or dominant form. So when it is present in autosomal recessive form, you can have Fanconi anemia, the BRCA1 mutation. So Fanconi anemia can present prenatally also. So first off, I would like to do a very detailed evaluation of the fetus and see if the fetus is showing any signs of anemia. There can be increased nuchal translucency or nuchal fold thickness. There can be radial ray defect and a very detailed evaluation of the fetal heart, structural and functional. Detailed evaluation I would like to do. And then proceed with the prenatal testing. So in this family, already we have a established autosomal recessive condition, which has affected the previous child. So we would be testing for that. And though many carriers status have been found in the couple for many conditions, since we are worried about the autosomal recessive conditions here, where both parents, if they are carriers only, then the baby is going to be affected. So we would like to explain to them that only these two conditions, where the SERF1 mutation and the BRCA2, sorry. So these are the conditions that we are worried about, and these two conditions we would like to test the fetus, and we
So,
can proceed with the prenatal testing.
but if would you like to also test or report for the heterozygous BRCA2 variant if it gets detected in this fetus?
I think at this point, first I would discuss with the geneticist who to counsel the couple accordingly. If the couple would want to know the carrier status, should we at all disclose that? Then only we can proceed with the heterozygous status of the BRCA2 gene. So, hello.
Yes, thank you, Dr. Gayatri. So, mainly here we are looking to offer testing for the homozygous SURF1 variant and the homozygous BRCA2 variant. But of course, if after counseling the couple do wish to know about BRCA2 heterozygous variant because they want to avoid the risk of cancer to their child, I mean, this is something which again most of the time we leave it to the couple to decide rather than and I mean dictating or enforcing our own opinions on them. So with this now, let's see the couple did undergo the testing and then eventually they have go back to the obstetrician for the management. So Dr. Manjula, now that this lady is found to have this BRCA2 variant, so would you also want to keep her on additional follow-up or any other surveillance measures which you would recommend for her?
Thank you, Dr. Shagun. Am I audible?
Yes, you are.
Yeah, because my internet, I don't know, is unstable, so I was wondering. Anyway, good evening and thank you so much for inviting me here. Yeah, genetics is always a very difficult subject for a general obstetrician like me. But as far as if a couple, I think, who have a BRCA2 variant, then they are at a higher risk for, as we know, the ovarian cancer, breast cancer. Then you also have a higher risk in men also for male breast cancer. I think both the husband and wife both are positive, I think, for the
Yes, that's right.
yeah, and also apparently there is a higher risk of pancreatic cancer and prostate and melanoma. So these are all the various cancers where BRCA2 mutation confers a slightly higher, I mean, a lot higher, especially with regard to breast and ovarian cancer. So surveillance for the woman definitely would be the clinical breast examination, annual MRI of the breast and mammograms, and also see, I am not really somebody who deals with these kind of women, but whatever I understand is there would be a time where, you know, once a prophylactic mastectomy would reduce her risk of breast cancer in these women. That is one. Secondly, regarding ovarian cancer and primary peritoneal cancer, prophylactic oophorectomy can be considered after she has completed her family. So these are all, at least she should undergo surveillance for ovarian cancer by a transvaginal ultrasound and a CA-125, although they are not as effective as for breast cancer screening. So that is what I understand, that when there is a BRCA2 mutation, they have to undergo these kind of surveillance, and a risk reduction surgery can be offered at an appropriate time for these women. Although I also believe that the penetration of this is not 100%. That is, if they do have this variant, it doesn't mean that 100% of them will get the cancer, but definitely they are at a higher risk, and surveillance for breast ovarian cancer has to be instituted in women, and risk reduction surgeries can be considered after they have completed their childbearing.
Yeah, thank you, Dr. Manjula. So, what we have seen here is that, using this expanded carrier screening, we have detected this additional variant. And although, yes, it would cause some anxiety and counseling challenges for this couple with respect to prenatal testing, but in a way, it has also helped to identify them at an early age that they are at risk of developing certain cancers, and it would benefit them subsequently, so that they can be put on surveillance and we could prevent, or as Dr. Manjula mentioned, we could encourage them for certain risk reduction surgeries also. So finally, to summarize this case, so what we are seeing here, first thing to understand is, yes, of course, mitochondrial inheritance per se is one of the mechanisms of mitochondrial disorders, but actually a large majority of them are caused by nuclear gene mutations only. And most of them are these autosomal recessive inheritance pattern. So they do follow the Mendelian inheritance pattern, and majority are the recessive condition. So that is one important thing. And then we need to realize that whenever this kind of workup needs to be done, if the previous child has been there, ideally it should be done early in pregnancy. So as Dr. Sumitra mentioned, so as soon as possible, refer the patient to a geneticist, because genetic workup takes time, and then you would need to do prenatal for them and in a suitable window. And of course, proband sample is the best. In addition, if sample is not there, then we have to test the parents. And otherwise also, sometimes in certain scenarios, certain couples would opt for an expanded carrier screening, but this has its own challenges. We could end up with more variants, and this could have both a positive as well as a negative aspect. And thereby, it's very important to do a pre and post test counseling whenever such kind of tests are offered. So now we'll quickly move to the second case. So here we are having a couple who is non-consanguineous, and they have previous two healthy girl children also. And they had actually been referred at 19 weeks, 6 days due to certain soft markers on scans. But when the history was taken and the pedigree was made, we found that there was history of a neonatal death previously on day 5 of life, and there was some oligohydramnios and some perinatal asphyxia, which was reported by the couple. But unfortunately here, unlike the first family, there were no records available. So we did not have any other information, no photos of this child or no medical records, reports were available here. So now when she came to us, so on scan, she had these two markers. They were a very borderline ventriculomegaly and also a megacisterna magna, and she was around 20 weeks. So at this point of time, Dr. Sumitra, so such a patient, like they come back to you with a scan report. So how do you proceed? What would you advise for this particular case?
Yeah, so Dr. Shagun, this case is having like a borderline ventriculomegaly and a large cisterna magna. So likely, one thing is that they need a very detailed neurosonogram. So just looking at these two aspects.
Ma'am, you're not audible, ma'am.
Hello, am I audible?
In slightly, your volume is little low, Dr. Sumitra.
Okay, am I audible now?
Yes, better, ma'am.
Okay, should I carry on?
Yes, please.
Yeah, so this fetus would need a detailed neurosonogram. That is one thing, because we have to look at all the orthogonal planes also, and if there are any additional findings that we can get. So that is one thing. The other thing is that if we just keep looking at the posterior fossa only, that too, it can be a evolving something which is evolving, because neural this thing abnormalities are evolving. So the brain is still developing. So they would need a follow-up scan also. And we have to counsel them that we can't make an appropriate diagnosis right now. You would have to be under follow-up, and you would need a serial, neurosonogram for evolving anomalies. And at this point of time, they would, of course, need genetic counseling as well. And because there could be various reasons for borderline ventriculomegaly and enlarged cisterna magna. It could simply be a dandy walker, it could be a Blake pouch, it could be arachnoid. So multiple things, and association with genetic analysis needs to be done. So I think a basic karyotype and array should be advised at this point of time, and they should also be, like as I said, kept under follow up. The DNA also can be stored, and as it evolves and we find more findings, we can go in for further testing. And of course, at this point of time, the geneticist also needs to be closely involved in the case.
So, Yes, so as Dr. Sumitra has said, so this case, yes, we did do an amniocentesis and the microarray turned out to be normal. So following this, at this point of time, we had reassured them and advised them for a follow-up to, as you correctly mentioned, to see if there were any evolving findings which would emerge later in pregnancy. So then when she came back at around 26 weeks, we did find, yes, there were additional things here now. So there were these periventricular echogenicities which had come up at this point, and there were also suspicion of certain microcysts in these echogenic areas. So the patient was referred to a neuroradiologist, and then these were the MRI findings here. So now I would call upon Dr. Nitin, who is also a radiologist and a fetal medicine specialist. So, Dr. Nitin, can you please describe these MRI findings and what would you be thinking if you would be seeing these findings on a scan for a 26 weeks fetus?
Yes, ma'am. Good evening, and thank you so much for involving me in this panel. So, what I could see from ultrasound image and MRI, so ultrasound are quite typical of CMV. There is mega cisterna magna along with the ventriculomegaly, right? So, I think if at the images, if I look for cisterna magna, it is somewhere around 11 mm and
13 mm
13
is the
mm.
cisterna magna. Yeah.
Okay,
Ventricles are 11 mm.
ventricles are mildly dilated, just mildly dilated, but still both are, in the criteria for CMV. Along with that, now what we can additionally see are the microcyst and some periventricular echogenicity. So these subependymal cyst may be, benign pseudocyst, but this is the time for neurogenesis for the fetus, the 14 to 28 week time. So we shall not take them lightly. And on MR, may I have the MR slides? So this is typically is below the ventricular line. If in the coronal plane, if I draw a line from the ventricles, these are below that. So most of the periventricular leukomalacias are above that line. So these are below the line. So most likely they are pseudocysts only. But all these are typical. And one more thing, these echogencities are looking quite symmetrical, and looking in the superficial white matter zone. And as of now, I don't see any sort of diffusion restriction. So, but still, either they go in the favor of CMB. And as in very first case, which you have shown, that in that baby, that 4-year-old baby which died, that girl baby, there in the brain findings, we could see that symmetrical T2 and flare hyperintensities. So symmetrical T2 and flare hyperintensities are highly suggestive for neurogenetic and metabolic disorders. So these I will think first of CMV, and second I might think about the neurogenetic thing, because we have a history of one male baby died at day 5. There was oligo and perinatal asphyxia. So just keeping in the screen. So
And
for
now,
me, yeah, so differential would be one is CMV, and the other one might be some neurogenetic thing, which may include mitochondrial disorders as well. So I will counsel them that, like you have already gone under the amnio. CMA is normal. We have a stored DNA, so we may go for whole exome along with the mitochondrial thing for the evaluation. And also MRI, we can, if patient can afford, then we may repeat MRI around 30 weeks or maybe 32 weeks. At time, polymicrogyria and all these things are much more appreciable in later gestation.
thank you, Dr. Nitin. So here, actually, this particular case was before the MTP, the law was modified. So she was already 26 weeks. So, and that particular time, we had done a torch profile that had turned out to be normal. So we had prognosticated at kind of a poorer prognosis, but because it was an advanced gestation, they did continue the pregnancy. And finally, now they went back to their obstetrician. So, Dr. Manjula, now that we have these findings, and as Dr. Nitin has told that he's thinking of these two conditions, differentials, CMV, we are thinking unlikely maternal torch is not showing any acute infection. So, probably this could be a neurogenetic condition. So, what would you like to tell your neonatologist? What to watch out for this baby? Does he need to collect any samples, given especially that the previous child had also died very early after birth? So would you want to speak to a neonatologist about this baby?
Uh, I'm really not very, I mean, yeah, the audio has been very bad for me for some reason. I
Oh,
don't
I'm
know.
so
I
sorry.
lost the thread. No, I think it's my internet which is unstable. Uh, Regarding communication to the neonatologist, I don't know really, but samples to be collected, I think definitely we do need to collect the cord blood samples and the placental bits for any analysis. No, I really am not very knowledgeable. You should throw light on this to me, Dr. Shagun.
So, no, basically, because here we are thinking of a kind of a neurogenetic condition and probably a metabolic disorder. So, we usually for a newborn to check for metabolic disorders, like we have these assays, as Dr. Udaya was also mentioning, like TMS, that is tandem mass spectrometry, which is done from the baby's dried blood spot, and a urine GCMS, which is done from the baby's urine. So here, we at least we could communicate to the neonatologist that to collect these samples of the baby, so that the workup, biochemical workup, can be done for the baby if required. So that's what I was trying to like come through these questions, that we need to. For one thing, of course, we are anticipating that this baby may be sick. So it would require more intensive care. And second, of course, because we are thinking about a metabolic disorder as one of the possibilities, we would want the samples to be collected so that we don't lose on those precious samples. So although we have the DNA of the baby stored here and we can do the genetic workup, but sometimes the genetic workup may reveal certain variants of uncertain significance. So which would need further corroboration by biochemical assays. So that would kind of collection of those appropriate samples at birth would become useful to do that biochemical corroboration. So that's what I was trying to elicit here. So I guess we'll go on to the actually what happened to this baby. So then this baby slightly on the lower side, born at 36 week, and within 9 hours of birth, developed respiratory distress, refractory seizures, and ABG showed a severe persistent metabolic acidosis, high blood lactate ammonia levels, and urine GCMS also showed high lactate and pyruvate. And unfortunately, baby expired on day 3 of life. So, Dr. Sunita, now, what would you now be thinking, ma'am? What could be the possibilities now for this baby? And we have seen that this couple has lost another baby also in the neonatal period. So, what test would you like to do now for this baby?
Yeah, thanks, Shagun. So, having listened to the entire story of this couple, they already have a first neonatal death with unknown cause. And in this pregnancy, there were issues and there were genetic testing done with normal results of chromosomes. So now we switch to the monogenic conditions, especially because there has been now a recurrence. Now this neonate has presented with an acute sickness, with severe sickness, and now we have some additional findings of metabolic acidosis and raised lactate. So there is a high suspicion of a genetic condition due to some gene involvement. It could be a mitochondrial disorder looking at the biochemical derangements. However, this mitochondrial disorder could be due to nuclear genes, or it could be due to a maternal, like mitochondrial DNA that can be involved. But more likely, it will be a nuclear gene involvement. So, what I would like to do is go ahead with the whole exome sequencing. And of course, if it's possible, we can also join in the mitochondrial genome sequencing as well. Thank you.
So, ma'am, we saw that, as Dr. Ratna said, that mitochondrial genome sequencing, I mean, if there is a mitochondrial DNA mutation, there would be, usually we expect or we think that there would be a 100% recurrence risk. It would be coming from the mother. Here they have two girl children who are completely healthy. So, could this still happen? I mean, that there could be a mitochondrial.
Yes, it can still happen because we have heard about heteroplasmy. So of course, the children come from the same mother, so they will inherit the mitochondrial DNA as well. But to which proportion? That's the biggest question. It doesn't have to be a homoplasmic inheritance. So that's why not all children will show the disease. They will certainly, if you test them, they may have a percentage of their DNA showing the mutation or the variant. But then if it is less, the lesser the percentage or the lesser the heteroplasmy, the higher the chance that those children will not manifest. So this is what happens in mitochondrial inheritance, which means inheritance due to the mitochondrial DNA, not the nuclear DNA. But here I would say my personal, if I were to choose, my personal feeling is that it is a nuclear encoded mitochondrial disorder, which will behave like any other autosomal recessive condition. And that's how those two girls are not affected.
Thank you, ma'am. So as Dr. Sunita has said, so that's what has turned out to be. So the baby actually was having these two variants in the FBXL4 gene. So this is a nuclear gene, which is encoding for a mitochondrial complex or maintenance of the mitochondria. So this causes this particular condition, mitochondrial DNA depletion syndrome type 13. This is autosomal recessively inherited. Dr. Udya, quickly, we are a bit short of time. So we found two variants in this baby. Both are heterozygous. Do we need to do anything further, or is it confirmed that the baby is having this disease?
No, ideally, we need to confirm that both the mutations are in trans. That is, one is coming from the mother and one is coming from the father. The baby is truly compound heterozygous. So we need to test both the parents for both the mutations to ensure which is coming from the mother and which is coming from the father. That can be done by a targeted variant testing. We don't need to do the entire exome for it.
Yeah, thank you. So here we did the target variant testing through Sanger sequencing. And yes, indeed, one variant was from the mom and the other was from the dad. So, so the baby basically had both the copies of the gene or both allele having one mutation each. So we confirmed that this is the condition which the baby was affected with, and most likely the previous baby also. So an autosomal recessive mitochondrial disorder, which is known to present in a huge proportion in the neonatal period and has all these multiple symptoms which I have listed here. So, Dr. Nitin, we are slightly short of time. So, just what are the MRI changes we see in patients after birth with mitochondriopathy?
So
So,
after
what are the
birth,
usual?
they may vary from neonatal period to the adulthood. So typically in neonatal period, we see symmetrical. There should be focus on symmetrical things like you have already mentioned T2 hyperintensities involving from basal ganglia, thalami, posterior brainstem, cerebellum, and subependymal cyst at time in neonates quite specific for Zellweger syndromes and we also must evaluate about the corpus callosum. Cerebral atrophy usually comes little late. So basically symmetric T2 or flare hyperintensities in basal ganglia, cerebellar and posterior brainstem involve also extending to the spinal cord. And these involves predominantly the superficial white matter in comparison to the deep white matter.
Yeah, thank you,
That's
Dr.
it.
Nitin. So the findings which Dr. Nitin has mentioned, so many of them are also, of course, reported with the FBXL for gene mutations also. And I'm not sure whether Dr. Sita has joined. Dr. Sita, yes, good evening. So yes, so we have seen that yes, in children, all these findings are there. So what about prenatally? Like here in this fetus, we had these findings on the scan. So, what are the prenatal presentations of mitochondrial disorders?
So obviously we don't suspect in the first place mitochondrial disorders when we see prenatally. So they were typically present, like in this case you've said, like features suggestive of an infection. and typically not very early, maybe in the second or late second trimester, or even in the third trimester, with all these features like mild ventriculomegaly or enlarged cisterna magna. Sometimes with polyhydramnios, they may present, and then you start suspecting if they have any other features when we're looking for infective sort of etiology. So if there are abnormalities mainly in the brain and like you said, periventricular cyst or or calcifications, all those features mainly that would suggest an infective etiology. So and sometimes you also have there was one case reported where they have cerebral atrophy and hypoplasia of the cerebellum as well. So because they are evolving findings, they are typically seen in the third trimester, and then you pick up and then you think of other things if the CMA and the whole exome is normal, because once, as you said, you don't suspect a mitochondrial deletion,
Yeah,
the first thing you think of the more commoner things, isn't it? Yeah.
yeah. So they are not something which we would typically actually suspect antenatally as such. So
Yeah,
although
yeah.
there are some reports of certain
Yeah.
findings, and here
But
also
those
we
have they been correlated postnatally after the child has been born, and then we sort of retrospectively go back and see
yes,
the
yes,
phenotypic evaluation of yeah. Thank
very
you.
true. Yeah. So, Dr. Manjula, so in
Yeah.
this particular case, like we saw that this couple did go through a kind of an unfortunate outcome where they lost a second baby also. So they were initially referred at 20 weeks. So would we have done anything different here? Like in the first case, we saw how, we were able to offer them um, a prenatal testing, offer them testing
Yeah,
for the
I
couple
think,
and all.
extremely preconception counseling is what I think you are referring to, and I
Yes.
would want every couple who have had lost their child like this to, have a second before they attempt the second pregnancy, to actually go to a genetics department like what you are heading, and let them get thoroughly investigated and have a plan for the subsequent pregnancy. Otherwise, you are lost at 20 weeks. What are you going to do with the, even if you diagnose anything and then the whole workup, it takes time, because MTP legally in India is only 24 weeks. Even if it is an anomaly, we cannot do it beyond 24 weeks. So this is extremely important. Preconceptional counseling coming very early and diagnosing early.
Absolutely. So that's the most important message I would say from this case, is that very often such kind of scenarios are because of genetic condition, and it's very important that they are referred in the preconception period or a early prenatal period to the right specialist, to a geneticist or a fetal medicine consultant, so that they can be completely investigated before they plan the next pregnancy, and we can offer them timely testing. And as another point here, of course, is that many of these findings sometimes can evolve late. So yes, nowadays prenatally we are offering many genetic tests, but it is sometimes difficult to correlate with the phenotype because it keeps evolving during pregnancy. So again, these are some challenges which are there even despite availability of advanced technologies. So we'll go on to the third and the last case now. So this is a non-consanguineous couple, and this lady actually, who herself is a doctor, so she already had a healthy girl child, and her brother actually had been diagnosed with Leber's hereditary optic neuropathy by the ophthalmologist, and he had an onset of progressive blindness from 20 years of age. So now she wanted to plan another baby, and she was really concerned about the recurrence of this condition in her next child. So I would like to first ask Dr. Sunita. So what is this particular condition, Dr. Sunita, and how does it differ from these other mitochondrial disorders which we just saw the previous two cases? So is there something unique about this particular phenotype?
Yeah, thank you, Shagun. So LHON stands for Leber's hereditary optic neuropathy. So it's a optic neuropathy, means there is a kind of a blindness which is hereditary, and so it happens in young adults. Majority of them are males, and it happens in a very painless manner. It can be sudden and it can be sequential from one eye to the other, and usually it is progressive and can be permanent. So this is what LHON is. It is a kind of blindness. And the inheritance is what makes it unique, because this is something that is inherited maternally, or it has a mitochondrial DNA inheritance. And that's where the heteroplasmy and the homoplasmy and all those concepts come in. It is not the genes in the mitochondrial DNA are the ones that are involved, giving rise to LHON. There are 3 or 4 genes, and there are 3, in fact, targeted mutations that are responsible for over 95% of the LHONs. So whenever we suspect LHON, one should not jump and do whole exome sequencing. Rather, we don't even need whole genome, a whole mitochondrial genome, but we need those 3 common mutations to be tested on the mitochondrial DNA. So does that answer your question about what
So
next?
whom should we do the testing here,
Okay,
Dr.
yeah.
Sunita?
So here the lady who had come to you for the asking for the thing, her brother is the one who is affected. So in genetics, we always pick the person who has the disorder, if he or she is alive. So that's how the brother is the one who needs to be tested, because he is the one who has the problem and the highest chance that we'll pick up a genetic fault in him. And then we go from there. So if it is LHON, which means maternal inheritance, which means that some degree of mutations would be coming to the sister, but it is left for us to discover what's the percentage, which means the level of heteroplasmy. Yeah.
Yeah, thank you, Dr. Sunita. So here, unfortunately, the brothers' reports, they were done, but they could not be accessed. So the lady herself underwent the mitochondrial genome sequencing. So she was found to actually have this particular variant. This is one of the common variants, as you mentioned. So there are 3 common mutations which cause this phenotype. So this is one of them, and she was having it. And she was also, the other part which was written in the report was homoplasmic. So now I would like to ask Dr. Ashwin. So would you like to tell us a little bit more about these mitochondrial DNA mutations? How common are these? Who transmits, and what is this homoplasmy, and how does now it impact this couple?
Yeah, so we already heard from Dr. Ratna that mitochondrial disorders can be caused due to both nuclear mutations as well as the mutations in the mitochondria. And we also saw how these are different from the nuclear mutations. So most of the mitochondrial disorders are caused due to nuclear mutations, since the mitochondrial genome only has about 13 proteins. And so very few of the conditions, one of which is LHON, where mitochondrial mutations are known. So as we discussed earlier, we should not jump to do a mitochondrial sequencing when we are suspecting a mitochondrial disorder, because many times we'll get it in the nuclear genome. But here, when you're suspecting a specific condition like LHON, here it's better first to rule out the mitochondrial mutation, and hence mitochondrial sequencing will be important. Now, mitochondrial mutations are exclusively transmitted by the mother, since only the ova has the mitochondria. And we already discussed about the homoplasmy and heteroplasmy. So homoplasmy refers to a condition where, so the thing with mitochondria is that there are multiple mitochondria within a cell, but there is only one nucleus within a cell. So the nucleus has 2 copies for each of the genes. Whereas in mitochondria, it is the multiple mitochondria, and within each mitochondria, there will be multiple the circular mitochondrial DNA. So if all the mitochondria have the normal mitochondria, then we call it as a normal homoplasmy. Whereas if all the mitochondria have the mutant DNA, then we call it as a mutant homoplasmy. But there are possibilities where few mitochondria may have the mutation and majority may not have the mutation, or majority may have the mutation and few do not have the mutation. These conditions are called as heteroplasmy, and depending on the amount of heteroplasmy, the clinical phenotype may vary. So that is why it is important to remember about homoplasmy and heteroplasmy during genetic counseling, that we need to explain to the patient that the variability of manifestation of symptoms in mitochondrial disorders can come from both homoplasmy, heteroplasmy, which may be seen also in a tissue specific way. And in addition, we also have the problem of penetrance. So LHON is one particular disease which is known to show different levels of homoplasmy or heteroplasmy, based on which the symptoms will be either severe or milder, as well as the sex dependent penetrance, wherein we see that males are 50% symptomatic and females are 10% symptomatic. That means although a female may carry the mutation, 90% of them may not show the symptoms.
So, as Dr. Ashwin has said, it is basically there are these various complexities are arising now due to this multiple mitochondria and the percentage of mutation or how many mitochondria are carrying the mutation. So, homoplasmic, as we saw, so all the mitochondrial DNA is mutated, whereas this heteroplasmy, depending on how many mitochondrial DNA have the mutation, this actually determines whether the patient manifests or not. And as Dr. Ashwin mentioned, it also depends on the tissues also. Some tissues may have more mutations, some may have less mutation proportion. So there's a lot of variability in mitochondrial DNA mutations. So, and in LHON, in addition, although most are homoplasmic, but the penetrance is not complete and it is really different for males and females. So now here for this case, I would like to ask all the geneticists. Now this lady is homoplasmic. She is completely unaffected. So now should we be offer her prenatal testing? Is there any role of doing prenatal testing if she plans a pregnancy again?
Um, Let me try and attempt it with permission from Dr. Ashwin and Udaya.
Yeah, please.
Okay. So the simple answer is it's very difficult and almost no, because of the complexity and the nature of the mutations being passed down from a mother to the child. It's very unlike the nuclear genome where you only have two copies and one has to come from mother and one has to come from father. Sometimes, rarely, there can be changes. But here there are so many copies, like one ovum, which is the future child, will have at least 100,000 mitochondrial DNA copies. So it really depends on what part of the mitochondrial DNA gets to go into each system, like the brain and everything. Before that, which part goes to the placenta and which part becomes the baby. So, because ordinarily, if we were to test for those mutations, you are going to either use the CVS tissue or the amniotic fluid. So CVS, I'm not sure how much reliable it can be to be truly depictive of the baby. So having said all that, with the complexities, people have ventured into it. And there have been studies in the UK, at least, where they have studied one variant, one Mela's mutation, the C.3243A2G. So we can say because of those, there is evidence if a lady is completely homoplasmic for that variant, it's possible to do a prenatal on the CVS sample. And if the CVS is homoplasmic, then you can safely consider that the fetus may be affected. However, not any otherwise. Because if there is any degree of heteroplasmy, you lose your surety or the confidence in being able to predict the status of the baby. And this, mind you, is only one variant in only one condition, nothing else. So we have 16,500 nuclear letters in the mitochondrial DNA and 100,000 copies. It's very difficult to do a prenatal if we are faced with a mitochondrial DNA mutation.
Dr. Ashwin, now would you like to add to that? Dr. Ashwin, Dr. Udaya?
Yeah, so I agree with that. So in addition to what Dr. Sunita said, again, there is a question of penetrance also. So even if the fetus is found to be homoplasmic, as we saw earlier, 90% of the females are not going to manifest. So then again, we are going to do prenatal in such situation where the penetrance is known to be very low. Then again, the ethical issue comes about whether we should do and terminate babies based on this. And the next scenario, what you are saying about the heteroplasmic, there it is even more complex. So in heteroplasmic scenario, ideally it's best to avoid doing a prenatal. But in a homoplasmic scenario, it will all depend on discussing with the parents and explaining them all these things. And then only going to this, because this will typically bring about similar to a Vivo US kind of a scenario where after prenatal, again, the question of penetrance and tissue specific load of DNA will come. So these are complex issues and there's no clear yes or no answer, I think.
Dr. Udaya, anything you would like to add? Yes.
So, ma'am, I think I'm in agreement with both of them. In fact, I feel there is not much expertise, at least available in India, to do mitochondrial prenatal testing, especially for plasmi levels.
And would that be through, I mean, to know the plasmi levels, we would need to do an NGS, right? I mean, it cannot be done through Sanger sequencing also. So that also would be.
Yeah, NGS and a very
And
deep
different
NGS.
pieces. Deep NGS, I mean, most of the times we're just doing an approximation of the plasmi. And ideally, what they would say is, I mean, even in a patient, you need to do more than one tissue. So there are so many layers to it.
Yes. Yeah. So, but here, I think one more thing is that if the lady is homoplasmic, I mean, we would expect that the fetus would be homoplasmic. It's very less likely that, because we are saying that the moms, all the mitochondria have the mutation. So, probably in this scenario, there is no role of doing any prenatal testing at all, because we know the outcome more or less that the fetus is going to be homoplasmic. Now, for LH1, yes, the other layer comes that the penetrance issue would come. So again, the phenotype cannot be predicted. Yes,
So
Dr. Sudha.
when we say homoplasmic, we have to really say completely homoplasmic, because we have only tested one tissue, which is blood. You don't know what is there
The
in the
status in
ovum.
other. Yes,
Yeah,
that's true.
so
That's
that's
true.
why the level of uncertainty.
Complexity is there.
Yeah, right.
Very true. Nice.
May I
So,
ask one question, ma'am? Here? Oh, okay, fine. Let's finish. Let's finish.
okay. So, Dr. Sita, so now listening from all the geneticists, all these confusing things. So, would you offer prenatal testing? Let's say she becomes pregnant and she comes to you, and then
Well,
what would
from
you
what
do?
I can understand and what I've heard, it is very, very complex. So a lot of counseling is required because possibly we might have more questions than answers. I think so. Basically, though we know that if she's homoplasmic, most of um, uh, the baby will be as well homoplasmic, but the level of penetrance, when the disease will occur, the rate of progression, everything is very difficult to predict. So, with a lot of counseling, I don't know if this can be offered in our country as well, as they said, but I would just offer them, of course, counsel them accordingly and take it forward from there. I don't know whether I'll be I strongly recommend it. Let me put it that way.
So coming back to our obstetrician, so Dr. Sumitra, now that we are seeing that probably this case, because she's homoplasmic, and then we are anticipating that there may not be much role of offering her prenatal testing. So what are the other options which can exist for this particular lady going ahead if she wants a healthy baby? So what all can we offer her?
So, do you mean the current pregnancy? Current pregnancy has
No,
already
right now she's not
where-
pregnant. She wants to plan a pregnancy. So we are anticipating because she has the mutation in all her mitochondrial DNA in the blood at least. So we are anticipating that the baby would also have the mutation. So probably there is no role of doing a prenatal testing or a PGT also from if she conceives using her own ovum. So what could other things we could offer her?
So one thing I just wanted to clarify was that even if she has her own progeny, like what has been discussed and what I understand, that in this, if she has her own progeny also and the fetus is homoplasmic, still she can be counseled that the fetus would would I'm thinking of
may not manifest in
may not
Yeah, so
manifest.
penetrance.
So,
in this
I mean, I
condition.
cannot be encourage her to have her own progeny, and if it is a female, then of course it's only 10% LHON.
Yes.
So that is one counseling. I mean, ultimately, of course, the couple have to take a decision. But if we can counsel and let them know that how much the fetus, the probability of being affected, and then if in case when complete penetrance of being as normal as she is currently, so the counseling plays a very important role in this case for her own progeny. And the other thing is, of course, PGT is again the same thing, that the variant load, if at all we are going to check in the PGT in maybe the oocyte or the embryo, but again the load may shift in the fetus. So again, we
Yes.
cannot confirm that this is going to help her. The other option, I suppose, would be a donor.
Yeah.
Right?
So
So
PGT with the donor ovum probably
Yeah,
would be one. If she's like, she wants to be really sure that the baby should not get a mutation. So one option could be a PGT with an donor ovum. So that could be one. Probably other things also could be sometimes, maybe not here for this condition because it has an incomplete penetrance, but more serious conditions like MELAS or MRF. If the mother is homoplasmic, then sometimes extreme measures like this. Or of course, we have this something new, which is now even legally available in the UK, mitochondrial replacement therapy or three-parent baby. But this particular couple, interestingly, I mean, she was a doctor herself, so they were not keen for any of this, these three. So there were some other things which are, of course, very, very questionable, but they were also thinking about PGT for gender, and then, taking the embryo, which is a baby girl, or an NIPT for gender, and continuing a female pregnancy where the baby is a girl and aborting the other. So, but these are, of course, in our country, something which we cannot really
It's
do,
a big
although we.
ethical issue here.
I'm not
Yeah.
sure if the
Yes,
PNDT would allow that.
yes.
So additionally, Shagun, I think we should
It's
also bear in mind that this is a late onset condition. I mean, not
yes,
so much as a
yes.
childhood. So we have to think ourselves about 15 to 20 years ahead. And with the fast advancements in treatments and all, why should we think that the situation is going to be the same? Right? So one
Yes.
could be more hopeful than what we really are.
Yeah, today. Yeah, that's so true. Yes. So these are all these, I mean, as we saw, I mean, all these complexities which do arise. So let's, not just this scenario, let's in general see like Dr. Gayatri now with all this discussion. So we saw that yes, for a homoplasmic patient, probably a prenatal or a PGT may not be that useful. But what about the ones who are heteroplasmic, and especially if it's a low heteroplasmy, like 20%, let's say. So in that case, prenatal testing, would it help? Which sample would you like to do, CVS or amnio? Dr. Gayatri?
No, ma'am. Now you have really put me on the spot. So actually, first thing is prenatal testing and handling is very difficult, like sir has mentioned, just like autosomal dominant conditions, which have variable penetrance and VUS conditions. First thing is that we don't have a phenotype to correlate with, or the phenotype has not yet happened. And also, there is only one shot attempt. Like we do a test when we interpret it. So because we have the upper limit of 24 weeks, and most of the time we do not have multiple opportunities to review and reassess the reports or whatever the reports that we get. And most of our prenatal tests are directed towards pregnancy continuation or termination. And only sometimes when the gestational age is far advanced, then the couple would be more willing to discuss about the treatment options rather. Early in pregnancy, mostly the couple are interested in about knowing whether it is affected and deciding on whether to continue the pregnancy. So here, when we have a low level plasmid, most of these conditions, 20 to 30% is the upper limit, which is considered that there is very low likelihood of the fetus getting affected. So here maybe just counsel them the risk is very low, and they may as well do away with the prenatal testing. And sample wise, it has been said that CVS sample yields better mitochondrial DNA rather than an amniotic fluid sample technically. But however, you've already mentioned, the mitochondrial DNA load is very much different in each tissue. So sometimes when there is mosaicism and all, it may not be really correlating with the fetal condition.
So I think in this situation, I mean, as Dr. Gayatri mentioned, so I mean, although yes, the load is less in the mother, but then we cannot really say in the ovum what could be the load, and it is possible that the fetus could have more proportion of the mutant mitochondria. So as in contrast to homoplasmic lady, I think this would be a patient who would probably benefit from an offer of a prenatal testing. And then again, but then the challenges, of course, are going to arise irrespective of the sample, because we will never be able to say the CVS load or the amniotic load, how exactly is it correlating with the actual tissue load in the brain of the baby or the muscle of the baby or the heart or the eyes of the baby, and eventually what will be the phenotype. So yes, I mean, people have attempted this, and there are some, I mean, based on the proportion of heteroplasmy in the fetal cells, we could to some extent predict, but then this is not, I mean, this is, as we can see, this is like extremely, there would be a huge gray zone where we cannot really predict the phenotype of the fetus. So I mean, Dr. Sunita, ma'am, you would like to add anything to this?
No, not really, because this is really a gray zone, and we should not. We want to be as clear as possible in a prenatal scenario. So,
yes.
If there is no, with no confidence or no surety in it, I don't think we should be offering it actually. So, but it depends upon the couple. So it's a
Yes.
debatable issue. Yeah.
Yes. I think counseling becomes extremely important
Counseling,
here.
absolutely.
Yes.
Yeah.
So back to our obstetrician, then they want to think about PGT. You know, a heteroplasmic lady, she wants to undergo PGT. So would you offer that? Is there any some? I mean, in the ovum, I mean, in the embryos or the blastocyst, is there any cutoffs and all which are there to say whether an embryo can be transplanted or not?
I have no idea regarding the genetic part, but see, implantation genetic testing will involve in vitro fertilization, the whole process. It is not a benign procedure, you know, the woman has to be stimulated and all that. And I don't know, maybe there is a role for this condition, PGT, in some situations. That is really, it's mostly theoretical for me. I can't add much to this PGT for in this situation. But it's not some easy procedure, is what I'm saying. It involves the woman to take stimulating drugs, and then the ovum has to be retrieved, and it's a expense. The whole, just the IVF part itself is expensive, and then you go on to this PGT, which there may be just for the purpose of, it is, she doesn't have a fertility issue. That's what I'm trying to say. It's for the purpose of a genetic testing, we are trying to do an IVF. So there are so many issues, and I think the couple have to be counseled, and everything, they have to be taken through the whole process. I'm sure there is a role for this in certain situations, where one of the the cells from the blastocyst is taken and tested for genetic analysis is done. So I really don't know much beyond that.
Dr. Sumitra, ma'am, you would like to add something?
I think it's like a real spot for us, because depending on the mutation load, I think if it is heteroplasmy, as you have discussed, that up to 20 to 30%, you really don't need to test. And if it is more than that, definitely that's a gray zone again. So it depends a lot on the mutation load. So, and again, as already discussed, that the mutation load may change in the fetus. So, I mean, the couple are ready to accept that, and they are going to undergo a prenatal also later. then I suppose a blastocyst, as you are already sharing, which has a mutation load of less than 20% may be considered safe for transfer, but would still need a prenatal again, post embryo transfer and once the pregnancy continues. And
I
I
mean,
think a lot of counseling goes into it.
despite all these challenges, as Dr. Manjula mentioned, I mean, very many couples are hell bent on having their baby. I mean, they don't want a donor ovum. They don't want to, go for others. So they really want. I mean, very often they do want their own baby by any means. They will go to any extent. So,
Ma'am, can I add something?
yes, Sudhya, please.
I think the first important thing before even talking about PGT in all these situations is find a lab or a place who's confident enough to accept the sample. I mean, I would be forefront to say that I don't even want to handle such samples. It's very difficult to estimate plasmy and to give out because you don't have so many positive controls. You don't have so many people taking up the test. We don't have so much expertise within India to, talk about plasmy levels confidently on which you could base your post-test
Decision.
counseling. So first you have to do the homework and tell them that, okay, we found some place who's ready to do it. So that could add on your expense also if you're planning to, send it outside.
Totally agree with that. Yeah. So
I
mean,
think we have to be upfront about it when we talk to the couples, because even if they get 1% of hope, they will actually latch on to it. If you say, okay, I'm try karenge, then they will of course want you to do everything. But if you say, like Udaya has said, that it's really not possible. I mean, why should we have to be upfront and say that this is not possible? So then they stop looking at it as an option and look at other options as well. So maybe the possibility will come a few years down the lane when we have more robust technology and we have more experience and there's more evidence of the recurrence and stuff like that, but not today.
Definitely. I mean, that practical aspects are really important. But I mean, this particular paper, what I just put this table, this is from China actually. And they have done all this modeling where they have mother's mutant load and what is the risk of
So this is
transmission.
computational, right? Because
Yeah, this is computational based on the empirical other pedigrees, and then they have done this computation. Yeah, that's there. And then there are studies which are saying this 18% load in the blastomere can be considered. But of course, I mean, we know that it's not really something which is available as of now in India, and how reliable this is even otherwise is really something difficult to say. So, I mean, anybody, Dr. Ashwin, you would want to add anything? Any of the other panelists?
May I have a question to all the geneticists?
Yes, Dr. Nitin, please.
Yes. So my question is, barring plasmy and penetration issue, if we know the mutation in mother, can PGT tell us the same mutation?
Yes. I mean,
we are actually
technically,
looking for the mutation, right?
And second thing, if we are going for donor OVA, then why do we need PGT for that?
no, we don't need.
Oh, no, one of the slide was mentioning PGT
Oh,
with
it's
donor.
Did I say? Oh,
IVF
sorry,
actually.
that's a mistake. Yeah,
It's not,
IVF with donor.
IVF.
Yeah, not PGT. Sorry.
Yeah. Thank you, ma'am. Thank you.
Okay, so I think this is just the takeaways from this case that these mitochondrial DNA mutations, they are much rarer, thankfully, because we know how to handle the nuclear DNAs. We know the Mendelian genetics and the counseling, and it is a precise science where here we saw in the mitochondrial DNA, there is so much of complexities and there is so much of layers which are coming. So in these scenarios, definitely a geneticist consultation should be sought, and there should be extensive counseling for these couples, and all these options which are there need to be really discussed. And of course, we have certain new avenues where people are trying these mitochondrial replacement, whereby they are taking the mitochondria from a healthy ovum and introducing the mother's nucleus, the lady's nucleus into that ovum, and then using this for an IVF. This is something which has got approved also in UK. So this is another thing which is coming up, which could probably give more hope to these couples. So with this, I think we'll come to the end of this panel.
Thank you. Thank you
Thank you
so
so
much.
much.
Thank you, Dr. Ratna and Dr. Shagun, for making this complex topic so simplified. And thank you, panelists, for your crisp answers. From the Society of Fetal Medicine, we are really grateful for conducting this panel. There are a few questions in the chat box. We are definitely running late, but we would want to answer these questions. So the first question by Dr. Aarti Raghu Kirani is that what is the bottleneck hypothesis? Dr. Ratna, if you could take that for us, please.
Ma'am actually has some internet issues.
Okay, so Dr. Shagun, could you take on that question for us?
Okay, so I mean, this bottleneck hypothesis is basically again in the mothers, the mutation load, especially the heteroplasmic women. So at the time of when it is these mitochondria are going to the baby or to the subsequent mature oocytes and also, they will not be distributing in an even manner. There's a kind of a bottleneck there whereby at the end what happens is that some ovum gets more mutated mitochondria, other gets the less mutated mitochondria. So that distribution in short, there are complex mechanisms, other mechanisms behind it. But basically it's a bottleneck whereby the distribution of the mutant mitochondria in the different ovum which are arising from this lady are going to be really varied, because of this kind of as if there is a bottleneck which is deciding that, how much mitochondria can go to one ovum, kind of a thing.
Right. Thank you so much. Dr. Sunita, you've already answered that question, but for the benefit of all, in case one, what tests should be done on the amniotic fluid, which Dr. Shagun has taken up? So, Dr.
I think the
Sunita,
question was for the first case where the
Yeah.
mutations were already known. So at that case, you only have to do those mutations. You don't have to do the whole exome.
Okay. So
And
I
it can
think
be done on the CVS also. Like she was just 6 weeks pregnant. So, she was in that window where she could also benefit from a CVS.
Right. Thank you so much. And this question from Dr. Medha is for mitochondrial disorders. Which test do we need to advise on prenatal sample? I think this has been answered and we've had a lot of discussion on this. There is another question which is not relevant maybe, but the question is that do we trust maternal torch at 26 weeks? Any of our geneticists could take on that question. The torch panel is coming up here, though not relevant to our topic today, but for the benefit of the audience. Dr. Shagun, Dr. Sunita, if you could take on that question.
The question is with respect to, I think that, whether at 26 weeks, the maternal torch serology would be relevant, because we are anticipating that the infection would have occurred much earlier, perhaps. I think that is the query, right? I mean, I am assuming that in this case, because the manifestations were starting in the, by 20 weeks, let's say, when the initial soft markers started coming up, if we assume, that is when. So, or if later also, let's say at 26 weeks, we are seeing some findings like this and we are suspecting infectivity also, probably the infection could have occurred later. I'm not anticipating that it would have occurred 4 months back or something. So it would still be relevant. At least I offer it, but I think the fetal medicine specialist would be better to answer, perhaps. Anybody, Dr.
Perhaps a more direct test would be like the amniotic fluid PCR if you have the samples.
Right.
Yeah.
Yeah, I think that answers it. Thank you.
It
There is
helps
another
actually to know the infection, because if it's CMV, then we could put her on treatment. We've had 2 such cases where we've put them on valacyclovir and we've had good outcomes. So I suppose, of course, it is significant to do a torch if there are ultrasound findings.
Thank you.
But this torch PCR, I just want to, for my own this thing. So there also what I reviewed is that that fetal infection also eventually that PCR also becomes negative after a particular duration, or is that not true? That's what my understanding was like. That could also come false negative, and besides the maternal torch serology also coming as false negative.
Yes,
that
option,
also.
that could be there.
The CMV tends to stay a bit longer.
Then there can be a false negative if the load is less, yes. But if there are ultrasound findings, then also one could think of Specifically, we've ruled out everything else. That if it is CMV, definitely now there is a treatment for it. Other infections, of course, other than CMV toxo.
Right. Right. Thank you. Thank you so much. There's still a question on why not do a full mitochondrial genome when it will be done in 5,000 and look for these mutations too, instead of doing targeted 4 mutations, which will cost more. That's Dr. Sunita, that question.
It's just a matter of cost. Of course, in earlier times, mitochondrial genome used to be very expensive and it was more cost effective if we did the direct mutation. But now there's no harm in doing the whole genome. So not a problem. You can also get the level of heteroplasmy as well if you go by NGS. So that's fine.
Right. Thank you. And Dr. Lakshmi wants to know that should the couple with BRCA2 mutation be advised lifestyle modification and also be given psychological support?
Yeah,
Would
definitely. Yes, definitely. I mean, for all these hereditary cancers, lifestyle modification is one of the things which is advised. And of course, they all require counseling also because there would be a lot of apprehension, anxiety, which would be arising with these reports. So that is besides other things like surveillance measures or risk reduction surgery. So those all interventions also would be discussed usually during the counseling.
Right. Thank you so much. I think I would convey my heartfelt gratitude to Dr. Ratna, Dr. Shagun, and our wonderful panelists. It was indeed an eye-opener for many of us who knew very little about the mitochondrial disease. And of course, the brain behind this entire event is Dr. Ashok Khurana. We would like to thank him, who believes that whatever it takes, we have to do our best for the fetus. And I think mitochondrial disorders is another area where we need to completely rely on the geneticists. So that's the take home, is that please consult a clinical geneticist and not take to prenatal testing just based on any report. Thank you so much. And I'd like to thank Dr. Bimal Sahani and Dr. Mohit Shah to always be with us, Vishalji for organizing this for us, and of course our trade partners, Strand and Agilis, to be here to support us in this academic event. And definitely a big thank you to all the delegates who stayed up so late for a topic we thought was very difficult and we would have a very small attendance. Thank you so much to everyone for today's webinar. Thank you.
Thank you.
Thank you,
very
Dr.
much.
Rima. Thank
Thank
you.
you.
Good night, everybody.
Good night.
Thank you.